Welcome all for today's yet another episode of Gurukul PATHSHALA. We learn every time some topic which is there useful in our PG studies also, in our practice also, and in our life also. So one of the topic is heart failure, and for this we have an expert also today, a very nice expert who will teach us from the pros and everything about the heart failure. For today's episode, to go ahead, I welcome our President, Madam Jhankhana Sanghavi, to her welcome address.
Thank you, Dr. Nehal. Good evening, everyone. I welcome today's expert speaker, Dr. Yogesh Sathe, sir. Welcome, sir. I welcome Gujarat HSD Dr. Nehal, Madam, Project Convener Dr. Lata and Vice President Dr. Sandeep Trivedi, sir. I welcome all attendee over here. See, heart failure practical management is a felt need of every PICU. Every pediatrician must have a knowledge of treating of heart failure. With today's expert, we get specific tips from our expert, Sir Yogesh sir, and feel confident in treating of a heart failure. So I welcome Dr. Yogesh Sathe, sir. And we all know the quiz is always a festival bonanza. So just enjoy the quiz. And over to Nehal, please.
Thank you. Thank you so much, madam. So for quiz, we will have Dr. Prashant KARIYA in a few minutes also. And I wish all the best to all the students who have regularly attending all the session and for going ahead with the quiz. So your participation means a lot, and there is a part of rewarding from us. I now hand over to Lata, our Chief Project Coordinator, for introducing Yogesh Sathe, sir.
Thank you, ma'am, for your kind words. Good evening, everyone. Today we are again with cardiovascular system with a very nice topic, heart failure in children, practical bedside management. So expert for today is Dr. Yogesh C Sathe, sir. He is head of department at Pediatric Cardiology Department, Sri SathyaSai Sanjeevani Hospital, NavaRaipur, Chhattisgarh. He is a very superb in his skills, and we'll know by the slides what he's going to give us for today. Well, most welcome, sir. And next second round is for by Dr. Prashant KARIYA, which is a very interesting quiz as ever. And now I hand over to Nehal, ma'am.
Thank you so much, Lata. And sir, so now it's all yours. You let us to the knowledge of heart failure.
Thank you so much, madam. Thanks for inviting me to this August meeting. And I share my slides and we can start the session with your permission.
Yes, sir. Please.
Yes, sharing the slides.
Visible?
Yeah.
Yes, full screen.
Welcome everybody. I'm Dr. Yogesh Sathe. I'm working as pediatric cardiologist in Sri SathyaSai Sanjeevani Hospital, NavaRaipur, Chhattisgarh. This is the first of its kind, completely free of cost heart hospital in Chhattisgarh, Central India region. I consider myself lucky to be part of this divine mission, which I call treating children totally free of cost. And we exclusively deal with congenital heart disease children, but also rheumatic heart disease and cardiomyopathies, which form a group of patients leading up to pediatric heart failure if not dealt with in time. So by definition, it's a defining paradox. Heart failure is a clinical syndrome, not just a low ejection fraction. That one thing we must know. ICMR has defined it as a clinical and pathophysiological syndrome that results from inability to have a completely normal function of the heart to supply metabolic demands of the body. International Society for Heart and Lung Transplant defines it as a clinical and pathophysiological syndrome resulting from ventricular dysfunction, volume or pressure overload, or combination of the things. This study group, Cantor et al., has defined in a more complete way. It is a failure of the heart to supply blood to systemic or pulmonary circulations at an appropriate rate to receive venous return at an appropriate filling pressure, resulting in adverse effects on heart circulation and the patient. So it is not a only low ejection fraction. It can be because of pump failure, that is ventricular dysfunction, or preload or afterload, affecting heart circulation and the whole patient. So it often has a treatable cause in most of the children. Identifying and treating this cause is therefore of paramount importance. We know, many of us, global perspective wise, high income countries will have congenital heart disease as the leading cause of heart failure, followed by cardiomyopathy. But in low and middle income countries like India and all the developing nations, rheumatic heart disease used to be the first and leading cause, and infected enteritis will tilt the balance and cause heart failure in children. But now congenital heart disease, with its increased awareness in primary care pediatricians and early referrals, and many of the congenital heart diseases are getting treated at various multiple units developing all over the country. Congenital heart disease has become the leading cause of pediatric heart failure in recent numbers. Age-wise, the causes of heart failure are, we all know, newborns will have duct-dependent circulations, which will be the most common lesions leading to heart failure: hypoplastic left heart, critical coarctation, critical aortic stenosis, or interruptions. Regurgitating tricuspid or mitral valves, or very rarely vein of Galen malformation or myocarditis in fetus or neonate, will be the cause for heart failure in newborn, first week of life. Remaining part of neonatal life will have VSD and coarctation, or large epipindo, or persistent truncus, or single ventricle with unrestricted pulmonary blood flow, PGA with shunts. VSD, PDA will have heart failure presentations within that first month of life. 3 to 6 months or up to maybe 1 year, we can say large post-tricuspid shunts like VSD, PDA, AP window, AV canals. Also, anomalous left coronary artery from pulmonary artery, myocardial affections in acute myocarditis, or those who don't get treated properly and go into dilated cardiomyopathy. All this substrate will be causes of heart failure in this age group. Beyond 1 year, it is myocardial affections, rheumatic valvular heart diseases, aortoarteritis, or palliated congenital heart disease, Kawasaki, or idiopathic pulmonary artery hypertension will be the causes for heart failure. So how we classify this condition? Various ways of classifying, like acute heart failure, which happens within few hours, or chronic heart failure happening over few weeks or few months. This is typically described in adults like heart failure with reduced or preserved ejection fraction. But in pediatrics, it is the other way around. Either mild and compensated heart failure or severe and decompensated heart failure, generally seen in single ventricles. The function impairment also classifies as systolic or diastolic dysfunction failure. According to the location of the heart, this is a very commonly used terminology: right heart failure, left heart failure, or biventricular failure. Cardiac output wise, it can be low output failures, like we see many times in pressure overload or volume overload, or contractility problems like myocardial affections, myocarditis, or high output failures, as we know, 3A, anemia, arrhythmia, or large AV fistula. That all will lead to tachycardia, fast heart rate, and failure, high output failure. Coming to the causes of congestive heart failure, congenital heart diseases are the predominant causes. Also complicated by arrhythmias, either SVTs or complete heart blocks also can cause complete congestive heart failure. Infections, myocarditis or sepsis, some form of sepsis will cause myocardial affection, and other rare causes of heart failure. Clinical manifestations of these are varying in age group wise. In infants, these are the main manifestations: fast respiratory rate, respiratory retractions, grunts, and difficulty in feeding as noticed by parents. Right heart failure will have sacral edema, that will be a conspicuous finding. Failure to thrive, if it progresses over time, and signs of renal failure, hepatic failure. But in older children, it will be cardiac wheeze or cardiac asthma. That will be a prominent thing in left-sided heart failure. Right-sided heart failures, they may show up JVPs, edema, ascites, or pleural effusions. And low energy levels, cold extremities, cold clammy extremities, exercise intolerance, or diaphoresis, hypotension, thready peripheral pulses, or decreased urine output. These are descriptions of clinical manifestations of heart failure in older children. The signs: cardiomegaly, either clinically or on chest X-ray, tachycardia, gallop rhythms because of increased flow across AV walls, or rapid filling of non-compliant ventricles will all lead to gallop rhythms, and low volume pulsations, cold clammy extremities, bounding arterial pulses in high output failures, growth failure, and diaphoresis, especially in infants while feeding, noticed by parents, tachypnea, wheezing, cramps, and mild cyanosis secondary to impaired gases, that is usually seen in severe heart failures and terminal phases, pulmonary edema like things. So what are the heart failure mimics? Sepsis, respiratory distress syndrome, inborn errors of metabolism, and bronchiolitis in infants. These are known as heart failure mimics, and they can be separated by clinical examination, very minute things, details, and yes, biomarkers and investigations will definitely come to a conclusion. Pediatric heart failure, thus, is fundamentally different from adult heart failure. Congenital heart disease, single ventricle physiology, or palliated hearts, cardiomyopathies become the most common group of causes of pediatric heart failure. Major pathophysiologies we should know before we proceed to management. We should know there is pulmonary overperfusion, volume overload, or pump failure, or pressure overload. All these mechanisms may coexist, but predominantly they lead to a classical clinical presentation of heart failure, which determines the outcome as the time when the child presents to us, either early, and early catch, we can have a good prognosis, but also prognosis is dependent on the cause as such. So we will come to each one in detail. So we need to know core compensatory mechanisms of the body. Scenario wise, what are the compensatory changes during pediatric heart failure, and what happens when decompensation sets in? So compensatory mechanisms in heart failure are mainly volume overload, pulmonary oversaturation because of shunt lesions, or pressure overload, outflow obstructions like aortic wall stenosis, pulmonary wall critical stenosis, or coarctation or interruption, primary myocardial dysfunction, and pump failure. But also this pediatric heart also has single ventricle or Fontan physiology failures. Arrhythmia is a very important substrate, and high output failures, as we discussed, 3As. Also thyrotoxicosis, thyroid storm. So coming to the first one, core compensatory mechanisms. These are the major survival responses of the body. They try to preserve the perfusion. Frank starting mechanism, it immediately starts. So within few minutes, this physiological ventricular stretching happens, which leads to excessive ventricular contraction and increased stroke volume and cardiac output. That tries to balance the cardiac output and maintain the equilibrium, homeostasis. So why does stroke volume increase with preload? It is because of better actin-myosin contraction coupling, increased calcium sensitivity, and reduced lattice spacing. So we know this very well. The mechanism is increased preload leads to increased sarcomere stretch, increased force of contraction, increased chronotropy, inotropy, dromotropy, all these things. In children, it is the volume dependence and stroke volume. But infants cannot rely on stroke volume to increase. They will respond with fast heart rate to maintain their cardiac output. That is the basic difference between infants and children. Then the second system compensatory mechanism is sympathetic nervous system activation, which happens within a few minutes and a couple of hours. The triggers are low cardiac output, decreased arterial pressure, and renal perfusion. So baroreceptor, carotid sinus receptor, arch receptors, they all sense this. And low pressure in cardiopulmonary receptors in atria or pulmonary veins also sense this low volume, and they cause activation of efferent system, causing beta 1 stimulation, alpha 1 stimulation, and kidney beta 1 stimulation. That in turn downstream amplification of renin-angiotensin aldosterone system, causing sodium and water retention, and short-term benefit is maintenance of BP. But long-term, it can cause beta receptor downregulation, myocardial oxygen demand is increased, and then myocardial fibrosis and apoptosis can happen. So this is in brief about sympathetic nervous system activation. Renin-angiotensin aldosterone system stimulation is the third one. It is a protective mechanism by the body. We know this from our physiology days. And angiotensin 2 causes systemic vasoconstriction, increased ADH release. So this ADH, vasopressin activation, happens over hours to days. So this, if goes on for a long time, will lead to water retention, ADH, vasopressin. So all these are effects of long duration of compensation. But hyponatremia in heart failure is a poor prognostic sign. Natriuretic peptides are the fifth compensatory mechanism. They are released by a stretch of myocardium. Brain natriuretic peptide and atrial natriuretic peptide are the two important natriuretic peptides. They are counter-regulatory. Trigger is because of myocardial stretch, and clinically we can use NT-proBNP, which is the inactive form but has a long half-life in blood, and it correlates well with heart failure severity in children. Ventricular remodeling happens in weeks to months, and it is either because of volume overload, it is eccentric hypertrophy, or pressure overload stimulates concentric hypertrophy, and cellular drivers, and these are the final outcomes. Either we treat the heart failure and we can prevent this fibrosis, stiffness, and diastolic dysfunction if we act in time. So after knowing this, how compensation differs depending on the lesion type. Mainly we need to know the large shunts will cause volume overload and pulmonary overcirculation and heart failure, like we have discussed. It will be tachypnea, excessive sweating while feeding, poor weight gain, repeated chest infections because of water-clogged lungs. It will be a very good harbinger for new infections to start. And repeated infections will always lead to hypercatabolic states, fast respiratory rate and catabolism, and will be cause of poor weight gain. Pressure overload from coarctation, critical AS or PS, systemic RV obstruction, all these cause concentric hypertrophy, and they are adaptive initially, but later on lead to diastolic dysfunction and heart failure symptoms. Pressure overload will cause coronary mismatch. It will be increased demand of the myocardium, and coronary will not be able to perfuse that much, and it leads to ischemia and subendocardial injury. Neurohormonal activation also happens, and it also worsens the afterload and shock-like presentation in duct-dependent lesions, plus pulmonary edema, gallop rhythm. All these presentations are likely. Myocardial dysfunction in myocarditis or dilated cardiomyopathy. These are also quite commonly seen children presentations. The heart failures are because of LV dilatation, functional mitral or tricuspid regurgitation because of annular dilatation, and all the adaptive mechanisms which cause sympathetic nervous stimulation or renin-angiotensin aldosterone system, progressively leading to fibrosis and apoptosis, which is the actual problem if not treated in time, we may lose the child, and the child will then go on for heart failure registry and then finally transplant registry, which is not a practical solution at present in our country like India because of very less available donor hearts. Single ventricle physiology and fontan failures are very precariously balanced physiologies and of pediatric cardiac specialty setting management. They have to be managed in a delicate manner. If it is a LV type of ventricle, we expect LVs to behave better. But if they are confounded by having heavy wall regurgitation or some rhythm disturbances, then such single ventricles may not cope on a long time basis. They will need some intervention deliberately. We need to keep them in very close follow-up. Single ventricle physiology occurs during staged palliation, like if single ventricle, Holmes heart is there, single ventricle and unrestricted pulmonary blood flow is there, then we need to band the child before 3 months of age. It is the recommendation. And then the child will go for bidirectional Glenn and then a fontan completion. So the systemic ventricle is the only pump of the heart available for giving systemic blood pressures. His respiration will drive the Glenn fontan circuit. So if any chest infection happens, definitely the child will land up in trouble. The fontan circulation will not happen because of the increased lung artery pressures, and we need to be very cautious. They should not catch up new infections. If happens, then we need to treat them very aggressively. Otherwise, the fontan pathway will fail. So these are all the adaptive mechanisms. Arrhythmia-induced heart failure, we quite often see tachyarrhythmiopathy. Repeated SVT paroxysmal attacks will sometimes, if not intervened properly, will lead to tachyarrhythmia-induced cardiomyopathy, which is definitely reversible, but over time may lead to heart failure symptoms because of disproportionate tachycardia, inadequate filling, and improper coronary perfusion and myocardial damage. So high output failures, 3As, they will lead to increased heart rate, stroke volume, the sympathetic nervous system stimulation, increased cardiac output, volume expansion, and bounding pulses. All will be having warm extremities, unlike cardiogenic shock. When compensation fails, the decompensation phase, this is the path to decompensation. Compensatory mechanisms are activated, increase in heart size, contractility, all are in the beginning, they are all helping the baby to maintain the cardiac output, but cardiotoxicity starts setting in, and then once coronary hypoperfusion, mismatch demand and supply, then myocyte injury happens because of hypoxia, then cell apoptosis because of the fibrosis sets in and progressively leads to decompensation and dysfunction. So these are the various reasons causing dysfunction, maladaptation and dysfunction. So various scenarios and volume overload, pressure overload, all these things lead to primary adaptation is Frank Starling and renin-angiotensin aldosterone system, but remodeling is eccentric, and if prolonged over time, then they lead to the myocardial fibrosis and all the scarring and all the things, plus pulmonary bed. In shunt lesions, pulmonary bed may react differently in different substrates. Some may be tolerant to high pulmonary blood flow. Some may go for early pulmonary artery hypertension, which is irreversible, like Heath Edward class 3, class 4 onwards. Similarly, coarctation and aortic stenosis or pump failure, DCM myocarditis, all we need to catch in time to avoid decompensation phase. Compensation is beneficial early but harmful later. That itself is a very important statement, and we need to know hypertrophy reduces wall stress but causes diastolic dysfunction. The dilatation maintains cardiac output but worsens mitral and tricuspid regurgitation, AV wall regurgitation, because of obviously annular dilatation as well as non-coaptation because of hypoxic damage in subendocardial region. The ventricular or myocardial stretch releases the brain natriuretic peptide, which tries to oppose this renin-angiotensin system, but finally becomes insufficient. So, how we manage this heart failure in children? We know we need to first assess these children in what stage they have reached us. So, modified Ross classification is the basic gold standard which has been given by Ross sir, and this grading came in Journal of Pediatrics. So we all know class 1, 2, 3, 4. Most of the children we see are class 2 children, but it is modified Ross classification. And for infants and child, they have different criteria for describing. So if we start describing those who are getting dyspneic on more than accustomed exercise for that age group, we consider them as class 1. Class 2 is those children who get dyspneic when they are doing accustomed exertion only. If that is class 2, then class 3 is those who get dyspneic while doing less than accustomed exercise. For infants, it is feeding. For child, it is playing with the peer group. And class 4 is obviously dyspnea at rest or grunting, diaphoresis at rest in children and infants. So heart failure severity we can grade in this pattern. The growth percentiles also can be checked in case of chronic heart failures. This is an important point to remember. Suggested clinical protocol for heart failure assessment, we need to know frequency of evaluation for stages. Clinical assessments will always have classification on Ross scoring system. NYHA we can use beyond 10 years of age according to the latest modifications and guidelines. Imaging for the congenital heart disease, heart failure children, according to the subjectively what all the recommendations are there for that type of congenital heart lesion. Rhythm assessment is a must. Also lab assessment in terms of the basic lab, complete blood count, C-reactive protein or procalcitonin if there is doubt. Then brain natriuretic peptide, but basic is we need to have ABG and lactate levels. That is a basic and well-established thing. Lactate should not be more than 2. It is a prognostication value like BNP. Exercise testing and cardiac cath is a last resort. It is only when we need to decide either operability for pulmonary artery hypertension, congenital heart disease children, or those who are idiopathic pulmonary artery hypertension, whether they are having response to treatment. Some newer things are coming up like genetic mapping of PAH patients, and there are various groups studying in America, in Australia, who are trying to do genetic mapping of all these children, various substrates, and some drugs will be beneficial, some will not be beneficial for such children with PAH. So what are the principles of management of heart failure children? We need to eliminate the underlying cause. Definitely there will be a cause and we need to find out and try to treat the cause. Treatment of the precipitating event, either infection or anemia or any arrhythmia. And then finally, control of the heart failure status per se. So work-wise, as we discussed, history is the basic thing. Physical examination and systemic examination of the heart. Chest X-ray will show cardiac enlargement, pulmonary edema, curly lines. The 12-lead ECG will be very much informative, as is pulse oximetry, ABG, and the blood lactates, CBC, electrolytes, liver and renal function tests, as well as electrolytes. Echocardiography for those who have for diagnosis of congenital heart disease lesions per se. Also, IVC volume status. The IVC volume status will be much deciding the ICU protocols and volume to be given during the treatment, as we see further. Chest X-ray useful for initial assessment, heart size and contour, pulmonary vascularity. Earliest sign is cardiomegaly before pulmonary edema. Pulmonary edema is the class 4 sign according to modified Ross. Echo, earliest sign is enlargement of filling chambers, atria. The left atrium in left heart failure or right atrium for right heart failure when there is diastolic dysfunction evident or decreased ventricular contractility, as we will see with decreased ejection fractions. Biomarkers do have a role in clinical medicine. They are well established in adult practice, but in pediatrics, we generally are trying to get a level, a normal level. They consider BNP level, NT-proBNP, as 60 as the cutoff for normal children. In 500 or above, if the BNP levels are that much at the time of admission, then it is a prognostic indicator. It carries a not that great prognosis if 510 and above are the BNP levels. Cardiac troponin I and T are for adult uses, not much tested and trusted for pediatric heart failure assessments. Natriuretic peptides are the stretch factors released from atrial or myocardial cells, and they have inactive form, that is NT-proBNP. It has a longer half-life and it is more relied upon while we test in labs. It has correlation with disease severity. It correlates with Ross classification and beyond 10 years with NYHA class, functional class, and correlates with echocardiographic ventricular function also. Outcome predictions for more severe heart failure, reduced ejection fraction, and adverse outcomes. They have prognostication value. Like I told, 507. This was the value given by this group, Selam et al. Demonstrated that BNP levels on admission can predict in-hospital mortality and prognostic marker rather than a diagnostic tool. So these are all the biomarkers we can expect over the next 5 to 10 years. They will come in picture, like galactin 3 or SST2 or GDF15. These are all recent advances. We may not go in details of that. Bedside hemodynamic profiles. This is the main table where we can classify either it is a wet or cold or warm shock or heart failure, and we can optimize the management accordingly. This is the basic table. Here it is nicely explained. Profile 1, no congestion in lungs and no hypoperfusion. Profile 2, there is congested lung but no hypoperfusion. Profile 3, hypoperfusion without congestion, and profile 4, both congested and hypoperfused. So this is also a very important table, and this will be the basic thing when we try to understand pediatric heart failure management. These are all comparatory for heart failure, ACC, AHA, NYHA functional classification comparisons, all given in the textbooks. I thought I should be dealing more with principles of management. Goals of medical therapy is, first we should have diuretics in volume overload situations. In pressure overload situations, we need to treat the cause. So if coarctation or critical aortic or pulmonary stenosis is there, we need to mechanically relieve it with percutaneous balloon dilatations. In enhanced cardiac contractility, for enhancement, we need to give inotropes, dopamine, dopamine. There is milrinone, which is called inodilator. Amrinone is the basic drug, but they have modified it to milrinone. Oral milrinone is also available these days. Afterload reduction, ACE inhibitors are the mainstay of treatment in long-term pediatric heart failure managements. Improved oxygen delivery and improved nutrition should be the goal in our management principles. There should be no residual lesions if child has congenital heart disease and undergone treatment. There should be no AV valve regurgitation. AV valve regurgitation can cause heart failures. Also, sequelae of congenital heart disease like AP collaterals in tetralogy or chronic hypoxia in compensated single ventricle hearts, palliated single ventricle hearts, those who could not undergo second surgery. So only Glenn is done and waiting for Fontan completion. Chronic hypoxia is there. So that sequelae of cyanotic congenital heart disease will always have heart failure manifestations, which may not be noticed because of repeated follow-ups and may not be parents may not be much because of in our settings it is very high demand and very few centers offering these treatments. We need to be very vigilant for even the delicate cyanotics can manifest with lot of hypoxemic problems which we may underestimate in the given circumstances, because cyanotic children are used to cyanosis, used to hypoxia. They will be very alert, very sharp, but they will have a lot of understable manifestations which we need to see. Comprehensive supportive management is the need of the hour in all these children. Optimization of nutrition, comorbidities. We should correct anemia. Exercise tolerance has to be given the priority. Also, psychological well-being has to be attended to. Nutrition, like I said, it improves the metabolic demands meeting. Also, reduced feeding efficiency because of the fatigue during feeding and tachypnea. So hypercatabolic state. So we can consider continuous NG feeds for circumventing malabsorption, gut congestion because of the pediatric heart failure per se can cause worsening of nutritional status. So we need to optimize. High risk for malnutrition in congenital heart disease and failure is increased metabolic demands but reduced oral intake. They have suppressed suck cycles, poor feedings, and because of the gut congestion, they will have malabsorption. So they will have failure to thrive, poor weight gain, poor healing, and increased risk of infections. So we need to have good nutritional assessment and we need to start them on hypercaloric formula. We need to avoid volume. So we need to concentrate the feeds. So enteral feeding formulas, nasogastric feeding formulas are the advanced nutritional support that we need to look for in infants and failing to thrive children. Parenteral nutrition in severe malnutrition, it may be required. Iron deficiency has to be circumvented. It reduces exercise capacity and increases the heart failure symptoms, and worse clinical outcomes are expected if we don't give adequate credence for iron repletion. Hypertension management is also a primary concern indicated in selected few patients. Those children who are found to have tracking of BP, if they are on a higher side, some time or the other they may end up in actual hypertension definition and can lead to heart failure if they go undetected, unchecked. So we need to treat them properly. But hypertension in children will definitely be a secondary hypertension because of some congenital lesions, either renal, or some acquired hypertension because of food habits. Chronic hypertension leads to increased ventricular afterload and ventricular hypertrophy and progressive ventricular dysfunction. We need to be having a cautious clinical approach. We need to look for residual structural lesions. If coarctation treatment has happened, ballooning, we need to look for whether there is recoarctation and that is causing persistence of hypertension, or child has refractory hypertension because of renal disease. So we need to have nephrology consultation in addition to pediatric cardiology consultation. So coming to ICU management of infants or children who have manifest pediatric heart failure, the 5 minutes first that we need to do positioning for offloading. In infants, hold against the shoulder or propped up position or infant seat. In older children, it is the high Fowler's position, which is the preferred one. Oxygen therapy. For normal anatomy hearts, we need to give humidified oxygen and we target saturation pulse oximetry of more than 92. But in shunt lesions or single ventricle, we can allow subambient oxygenation with targets of 75 to 85%. If we give high oxygen, pulmonary overcirculation and further deterioration can happen. IV access, like all ABC, we need to have proper IV access and fluid charting with fluid restrictions. That is the further go. The liver line shift to shift assessment every 8-hourly, 12-hourly assessment has to be a rule. Receding liver line means successful diuresis and dropping line is indicative of worsening right heart failure. Perfusion quality, the capillary refill time or core to peripheral temperature gap. We need to check both if possible. Heart sounds, any new sound or gallop rhythms need to be checked. Respiratory patterns and respiratory retractions or some adventitious sounds like grunts, rails, wheezes. Fluid balance and output tracking has to be very strict, and we need to maintain at least 70 to 80% of normal maintenance for that age group. Urine output targets should be more than 1 ml per kg per hour in ICU settings. For that, urometer bag or diaper weighing every passing or at least every 3 hours has to be the rule. Daily weight protocols. Every weight of that baby has to be checked at a specified time according to the ICU setups. And the same scale, and if there is a sudden weight gain, definitely it is because of fluid overload, not because of the growth. Pharmacological vigilance, like we said, IV furosemide, loop diuretic, is the drug of choice for treating these children. Safety check has to be done with basic metabolic profile and serum potassium has to be maintained more than 4 millipaths. Inodilator, which increases the contractility, plus there is peripheral vasodilatation, that is inodilator or lusotropic effect. So milrinone infusion has a standard dosing of 0.25 to 0.75 mics per kg per minute, and we need to have BP monitoring every 15 minutes is the ideal requirement. High density nutrition, as we discussed, has to be calorie dense because we have to avoid fluid overload in this failing heart. Feeding strategies have to be like we need to utilize a 20-minute feeding rule. We should restrict oral attempts and give the remaining feed by NGT, or we can go for 24-hour enteral pump feeding in severe decompensations. Critical bedside nursing care checklist, what we have written here. Also, for continuous monitoring of heart rate, respiratory rate, the multi-monitors are the best things that gives ECG, pulse oximetry, and respiratory rate and the temperature points. Liver margins, basic metabolic profile, IV fluids, IO status monitoring, and scheduled rest clusters are one thing which we can definitely do, grouping the nursing tasks together to allow uninterrupted sleep and minimize the oxygen demand, because if the child wakes up because of the nurse around, he will cry and will definitely lead to more myocardial damage than we are treating for. So these are the red flags. Notify the healthcare provider immediately. The nursing people or the duty doctor has to notify if there is some increase in respiratory effort or these red signs, grunting or desaturation episodes. Oliguria is not acceptable. If urine output drops to less than 0.5 to 1 ml per kg per hour, has to be over 2 consecutive hours. We need to act on it. If narrowing of pulse pressure or sudden systolic drop is there, or liver line is moving downwards, or there is severe diaphoresis on sustained crying or sustained tachypnea during short feeding windows, these are all red flags. So yes, definitely it is pharmacological therapy which is the mainstay of treating a child heart with failure. But these guidelines, pharmacology things, are extrapolated from adult heart failure guidelines. And many times we do not have much randomized controlled trials to support this as a evidence-based medicine. So heterogeneous anatomy, multiple surgical stages and different ventricular morphologies are the heterogeneous group that we deal with when we treat pediatric heart failures. So diuretics are the mainstay of treatment, and they are the loop diuretics. We all know about this pharmacology very well, and all these preferred agents are causing loss of whatever the water retention and sodium retention has happened. We try to counteract by these loop diuretics. Renin, angiotensin, aldosterone system inhibitors are the spironolactones. The enalapril group, angiotensin converting enzyme inhibitors, are the mainstay these days. They act on RAS system. They have well established, enalapril is a well established drug today for long-term treatments of heart failure in children. Natriuretic peptides, like we know, they are the recent advances, and this ARNI, sacubitril valsartan, is a combination of ARB, angiotensin receptor blocker, and neprilysin, that is the blocker for BNP. So sacubitril and this combination, valsartan combination, it is approved by FDA for pediatric heart failure beyond 1 year of age. Some new things, new medications are also coming. Beta blockers are well established in adult heart failure treatment, not much established in children. Like I said, much of evidence-based medicine is lacking for children. RCTs are lacking in children. But yes, for DCM, carvedilol we are using. Spironolactone is also a well-established drug. It is a remodeling drug. It prevents fibrosis. Digoxin has a specific role in single ventricle physiologies. The digoxin use has reduced from what it was 2 or 3 decades ago. SGLT2 inhibitors are the novice things, and sodium glucose transporter 2 inhibitors. They are showing promise. Not much used in children, but definitely, and this very sequat, both drugs will come in play over next decade or so for as a new heart failure drug, and is ivabradine also. This is mainly used for sinoatrial tachycardia, if channel inhibitor. Arrhythmia control is the mainstay. If we detect some arrhythmias, we need to act on it, refer to electrophysiologist and get it sorted out, because arrhythmias can cause problems with like tachyarrhythmiopathy, or bradycardia will cause ventricular dysfunctions because of diastolic dysfunctions per se, and we need to correct these lesions, have EP study and ablation. If bradyarrhythmias, then permanent pacemaker, or if some VTACs are there. ISCD implantation or CRT is an option for adults, basically. These are all the devices I don't want to spend much time for. Mechanical life support like ventricular assist devices are the recent advances which are used in all the developed countries. And finally, heart transplantation in these congenital heart disease related heart failures is the final option. But then we need to know these stages of heart failure and potential therapies which we can extend for these. This chart from ICMR will give it in most comprehensive manner. I thought I will include this. So drugs which we need to avoid in heart failure: NSAIDs, calcium channel blockers, metformin, antiarrhythmics, which we need to prescribe only with electrophysiologist consultation, otherwise can cause sudden deaths. So this is the simplified algorithm. ICMR has also taken this algorithm and given us if there is hypotension, tachycardia, respiratory distress, or GI distress. So class A, class B, or class C, and give these medications depending on ejection fraction. So echo comes into play, X-ray comes into play, and definitely ICU and bedside management is the hallmark of doing this simplified algorithm maneuvers. And heart failure management is the need of the hour because lot of medications, pharmacologic advancements have come. These are 4 pillars of pediatric heart failure management these days. They call ACE inhibitors, beta blockers, spironolactone group, and this new sodium glucose transporter 2 inhibitors and vericiguat. This is the pillar of heart failure management, 4 pillars. And these are the data. So pediatric data is quite less. We have good data for loop diuretics, but as we go down, the evidence is much less for use in pediatrics. So clinical practice references, I have taken these slides and information from ISHLT guidelines, ACCAHA scientific statement, PALS protocols, and nutritional consensus. So to conclude, there is a changing landscape for congenital heart disease, and complex congenital heart lesions are also surviving because of improved surgical repairs and availability at multiple centers at multiple places, and involvement of so many schemes, Prime Minister scheme, Chief Minister scheme, and various funding agencies, and so many large-hearted groups and personalities who have helped these young parents with congenital heart disease children who are getting treated. So our burden of those who are treated or partially treated, so that burden of congenital heart disease or pass outs, that I say, congenital heart disease pass outs is increasing. So heart failure can happen if there is some tipping point, like some anemia happens or some chest infection happens or some untoward thing happens which tilts the balance of these congenital heart disease, either untreated or treated children. So this is a leading cause of mortality in adults, but in children, if we treat these hearts, definitely they will give fast reply. But yes, we need to do this pediatric heart failure in consultation with a pediatric cardiologist. Thank you so much.
Thank you, sir, for such a wonderful presentation.
Thank you.
Some questions.
Sorry, I think exceeded the time limit too much. It was quite.
No, sir,
I thought I should
never
share these things. Yes, madam.
Yes,
I
yes,
told
sir.
that
Actually,
yes,
the
sir,
heart
never.
failure is such a vast topic that it's going to take some more time, and then we all wanted to learn, so it's not a problem at all, sir. So thank you so much, sir, for such an elaborative talk on
I
the heart
thank you,
failure.
madam, for inviting me to this very nice concept of having lecture series for each specialty every month, and 4 Thursdays and 4 different types of discussions that helps MD students, DNB students. It was missing during my MD days. I can remember from Vijay Medical and Aarti Kedikar madam and Anand Deshpande sir, Gambhir sir. They used to teach me, but this very pointed treat, I call it a academic therapy for these MD students. They are very lucky. This batch is very lucky. Last 10 years or so, and this boom of IT after COVID times. So that has definitely catapulted this into a very booming thing.
Yes, sir.
Thank you so much.
Certainly, sir. Thank you. Thank you so much. So now the platform is handed over to Dr. Prashant KARIYA, our treasurer of AOP Gujarat and the person who doesn't need any introduction. So Prashant, it's all yours.
Yeah, thank you so much. And thank you so much, sir. It was really a wonderful presentation. Please watch our quiz and guide our participants. Participants, those who have attended today's lecture, 50% questions are from this presentation only. So you will be having a benefit. And before we begin, we do have our academic quiz partners, Zorvia, Mr. Abhishek Kalyankar. If you can just say in 2 minutes, welcome everybody.
Sure. Good evening, respected doctors. My name is Abhishek Kanyalkar, and on behalf of Zorvia Healthcare, I thank you, sir, and the entire team for giving us this opportunity to be associated with such a wonderful initiative. We would like to thank the entire team, led by Dr. Yogesh Parikh, sir, Dr. Prashant KARIYA, sir, Dr. Baldev Prajapati, sir, Dr. Sandeep Trivedi, Dr. Lata Jha, and the excellent talk by Dr. Yogesh Sathe, Dr. Jhankhana ma'am, Dr. Kirit Sisodia, Dr. Jagdish Khamar, Dr. Nehal Patel, and Dr. Jigren Shah. Thank you once again, the entire team, for giving us an opportunity to be associated with such a wonderful academic initiative, because at Zorvia, we are always keen to be associated with such kind of academic initiatives. I also take this opportunity to share an important update. At Zorvia, we have got into a marketing and distribution rights of critical care, which includes all injectables and gynac portfolio of 2 divisions of Eris. So this is an important update which I thought that I must share with the entire medical fraternity over here. So with this, we have the entire basket of oral brands as well as our injectable offerings. And we would request on this platform, I request all the doctors to kindly support us in this journey towards patient care with our innovative offerings. Once again, thank you, sir. Thank you, the entire team, for giving Zorvia an opportunity to be associated with eGurukul and AOP Gujarat. Thank you, sir.
Yeah, thank you so much. So those who are on the Zoom platform, they know how to join Kahoot. We have kept the link of Kahoot into the chat. Even we are just sharing it to the different platforms and request everybody to join. Once everybody join, we will wait for a minute and then we will start. So today's quiz will be from the main 3 things. One is pediatric cardiology, ECG lecture taken by Dr. Ritesh Sukharamwala. Second, a panel discussion. And third, today's expert talk, which we are having. Those who have joined previously, they know how to play Kahoot. And those who are for the first time, for them, I'm just saying that you have to enter to www.kahoot.it and enter the game pin. The game pin is 4688862. Even you can scan the QR and from that also you can start. So I'm just starting this quiz. Anybody who wants to join can join by entering the game pin 4688862. So let's play Kaun Banega Champion. I hope my voice and screen both are visible.
Yes, Prashant.
Okay. So coming to the first question, what is the real expression in the photo saying? तुझे देखा तो ये जाना सनम, मेलोडी भी टेस्टी होती है सनम, खाई के मेलोडी इंडिया वाली, खुल जाए बंद अकल का ताला, आंखों में तेरी अजब सी मेलोडी है, and chocolate melody, lime juice, ice cream, toffee. So yeah, so everybody is answering, and for this question there is no marks, but you know that you have to click red, blue, yellow or green, that is there. Okay. Coming to the next same question, public reaction after seeing the flying cockroach Janata Party. All is well. Bhag DK Bose. Kitne cockroach the? And you are a disco dancer. So good. I mean, almost all are answering in 10 seconds. So that means everybody is there with us. And all the best to one and all for playing this. And remind you, again, we are going to give 15,000 rupees prizes. And there will be some explanation of the questions. So all the best to everybody. Let's the best player win. The first question. In unit, what is the normal ECG finding? A right axis deviation, a left axis deviation, a dominant S wave in V1, upright T wave in right chest leads. So this was the first session, which was taken by Dr. Ritesh, and he said and showed to us that in newborns, because there is a right ventricular domination, so majority are right, because it's a right ventricular dominance, the right axis deviation is there. And the top person in this is YP with 958 points. So congratulations, YP. Okay, a next question. Which arrhythmia shows RR interval variation synchronized with respiration? So that is most important. A ventricular tachycardia, atrial fibrillation, atrial flutter, or sinus arrhythmia. So this arrhythmias will have a RR interval variation with respiration, and rightly guessed by 43 people, that is sinus arrhythmia. That is the correct answer. Sud is at the first place now. A ventricular tachycardia is typically associated with narrow QRS complex, short tooth flutter waves, short PR interval, wide QRS complex. 50 people have answered in 10 seconds only. Good. And the correct answer is wide QRS complexes. That's why we say a wide QRX will be a ventricular tachycardias. Good. A Sitara name itself says first. Good. A double point question. Which ECG feature is characteristic of atrial flutter? Delta waves, short tooth F waves, peak T waves, and absence of atrial activity. Again, we got 45 answers within 10 seconds, and rest, please, the scores which you are getting are actually because of your speed. And the correct answer, almost all have given the correct answer. So that means Dr. Ritesh's session was very good. A short tooth F waves. Okay. Which congenital heart disease physiology is associated with decreased pulmonary blood flow? That is PGA without pulmonary stenosis, TAPVC, truncus arteriosus, and tetralogy of Fallot. Yogesh sir, if you can see, 50 people almost are giving answer within 10 seconds. So this is fastest finger first, and yes, the correct answer is tetralogy of Fallot, because in that there is a right ventricular outflow tract obstruction which leads to decreased pulmonary blood flow. Coming to the next, Sitara is still at the top and Vikas is coming. JJ is the highest climber. A child with recurrent palpitation has a regular narrow QRS tachycardia at 220 per minute with absent visible P waves. The diagnosis is SVT due to AVNRT or AVRT, atrial flutter, ventricular tachycardia, and sinus tachycardia. So this is actually, again, 50% answers already been there. We wait for some other answers. That at any age, if a QRS complex is narrow with tachycardia of 220 per minute with absent visible P waves, it is a SVT and mainly due to the AVNRT or AVRT, and that is regularly been taught during our PG sessions as well as in the ALS sessions which have been attended. Next, which arrhythmia is described as irregular with more than 3 different P wave morphologies? So that is most important. A ventricular tachycardias, atrial flutter, AVNRT, or multifocal atrial tachycardia. Good. People, please answer fast. We already had a 55 answers. People are playing well. And the correct answer is multifocal atrial tachycardia. Because of that only, it is multifocal, because from the atria, when the SA nodes is getting that generation, and this irregular heartbeat is coming, that giving a different P wave morphology, and that is most important. So now Vikas is at the second, cut to cut. A double point question. Differential cyanosis classically refers to pink lower limbs and blue upper limbs, both lower limb cyanosis, blue tongue with pink extremities, and blue lower limbs with pink right upper limb. So out of the 59 answers which we got, the correct answer is given by 35 people, and it is blue lower limbs with pink right upper limb. That is a differential cyanosis which is there. Next question. The adenosine terminates tachyarrhythmia in AVNRT primarily because it produces transient AV nodal block, increases atrial refractory period, suppresses SA nodes automatically, and blocks ventricular myocardium. Yeah, so the correct answer again given by 27 people, that is produces transient AV nodal block, and that is correct. Now we have a new person, Nihar, on the block. Let's move forward. A cyanotic newborn deteriorates after ductal closure and has pulmonary atresia. What should immediate management include? That is sildenafil therapy, the prostaglandin E1 infusion, the oral propranolol, or the IV digoxin. Okay, and this is very good. Out of 56 answers, 55 have given a correct answer, and that is true prostaglandin E1 infusion. Because the ductal closure with pulmonary stenosis will cause a problem, so we have to keep the duct open. Okay. Next, what is the most common cause of heart failure in infants aged 3 to 6 months? Complete heart block, large left to right shunt, rheumatic heart disease, or hypertrophic cardiomyopathy. Now the question starts from today's presentation. Those who have attended today's presentation will be at advantage, sir.
Yeah, many have attempted
Yes,
the question fast.
Yeah. So this is large left to right shunts, and majority have given the correct answer, sir.
Nice, nice.
Yeah. Coming to the next question. In pediatric heart failure, what is usually the earliest clinical sign? Sir has said in very detail, a tachycardia, a peripheral edema, cyanosis, or ascites. Again, same. I mean, out of this 58 people who are attending, 55 are right, sir. And that means they have attended very well. That the tachycardia, the compensatory mechanism, is the earliest sign which is there. Okay. Next, a double point question. Which mechanism explains increased stroke volume with increased preload? Bainbridge reflex, ward width effect, Frank-Starling mechanism, or the Winskill effect? Yeah, so out of 60, again, sir, 57 are right. They have attended very well. That the Frank-Starling mechanism is the mechanism related to this increased stroke volume with increased preload. Okay. Okay, next. What is the most common remodeling pattern in volume overload lesions? That is concentric hypertrophy, a restrictive remodeling, eccentric hypertrophy, and septal hypertrophy. So out of 59, sir, the answer is eccentric hypertrophy. Can you just explain it once again? Because out of 59, only 21 have given the correct answer. A most common remodeling pattern in volume overload lesions.
So the volume overload will be determined determinant cause of the stretch, and because it is always going to be a tussle between the various dynamics, it is not a point obstruction, it is the volume that is creating this excessive elongation. It will always be eccentric hypertrophy because of the ventricular vectors and forces that determine the actual outcome. Eccentric hypertrophy is the norm for volume overload. Pressure overload will cause concentric hypertrophy in the remodeling patterns.
Yes, sir. Fine. So good explanation, and good that 21 people were there, and this changes the scenario. Sitara was first and now Shilpa is first. Okay. Next, infant maintains cardiac output predominantly by increasing peripheral resistance, stroke volume, heart rate, or hemoglobin concentration. Now, this cardiac output can be increased by many mechanisms, but the mechanism which is most common with the infants is increasing heart rate, and correctly said by almost 50 people. So, good. Next, what is the hallmark symptom of heart failure in infants? Again, if you attended, hematuria, constipation, sweating during feeds, or polyuria. So those, yeah. So this is 100% right, sir. The 100%, 60 out of 60 have given a correct answer, that the sacred cycle or a sweating during the feeds, which will be there, is the hallmark of your heart failure.
Nice.
Next, a BNP is released mainly in response to hypoglycemia, hypercalcemia, myocardial stretch, or hypoxia alone. Yeah, and again, sir, all 59 are right. It is due to a myocardial stretch. So they are benefiting a lot from attending the session live.
Great.
Yeah. Okay. What are the preferred first-line diuretics in pediatric heart failure? Again, if you attended this, then this is very easy. Osmotic diuretics, carbonic anhydrase inhibitors, potassium-sparing diuretics alone, and loop diuretics. That is the first line diuretics which should be used. And all the answers, again, sir, almost 56 are right, apart from 2. So that is a good thing that everybody was attentive and well learned.
Nice.
Yeah. So which biomarker correlates best with the severity of pediatric heart failure? NT-proBNP, LDH, ESR, or CPK-MB? Again, 53% are right that it is NT-proBNP. So good. Which lesion commonly causes pulmonary overcirculation? That is coarctation of aorta, severe PS, critical AS, or large VSD? Yeah, so 47 people are right that it is large VSD because of the volume overload that is happening. And in others, the PS, severe PS or critical PS, there is a obstruction. So it will not cause the increased pulmonary circulation. Next, a double point questions. Hyponatremia in HF is considered as marker of dehydration, benign finding, poor prognostic sign, diagnostic of SIADH alone. Yeah. So it is a poor prognostic. Sir, again, if you can just throw some more light on this so that the audience will get benefited more. Why hyponatremia is considered as the poor prognostic sign?
It is the what we saw, the adaptive mechanisms. When they are overstimulated, it will lead to decompensation. So decompensation phase has reached. So hyponatremia is the decompensation stage of heart
Yes.
failure. So that
Yeah.
is the poor prognosis.
Perfect, sir.
Yes.
Yeah. Next, which drug infusion is commonly used as an inodilator in pediatric heart failure? A dopamine, milrinone, digoxin, adenosine. Yeah. And almost all, sir, out of 60, 56 are right that it is milrinone, which is the inodilator. So that is excellent attention and excellent participation from one and all.
It is also called lusotropic effect.
Yeah.
The inodilator.
Yes,
it is also called lusotropic effect.
Yes, sir. A double point question now. Oxygen therapy in single ventricle physiology aims for SpO2 of more than 98%, more than 95%, 100%, or 75 to 85%. And this was very well shown by sir in this slide, and it was also understood that whenever we do have a single ventricle physiology, at that time a target of 75 to 85 is okay. There can be a harm of hyperoxia in this cases, and because of that the saturation target range is around 75 to 85 and not more than that in case of a single ventricle physiology. Okay. Next, which arrhythmia can cause reversible cardiomyopathy? So that is sinus bradycardia, first degree AV block, persistent SVT, or junctional rhythm. Yeah, so it is correct, persistent SVT, because that can cause reversible cardiomyopathy, and once you treat it, that can be reversed. So good. Next, a double point question. What is the preferred position for a child with acute heart failure? Prone position, Trendelenburg position, high Fowler position, or a supine flat? So when you put patient typically in the high Fowler position, the venous return to heart decreases, and that will help in the acute heart failure. So majority are right. That is, a high Fowler position is the correct thing. Okay, next, true or false? Potassium should remain above 4 mole equivalent per liter during diuretic therapy. True or false? So this 56 answers came in 10 seconds. Next, wait for the others. Yes, it is true that it should be more than 4 milliequivalent, because the hypokalemia can actually worsen the cardiac contractility and there will be other issues. So you have to maintain potassium above 4 while you are giving a loop diuretics, and that is the first line. So you have to maintain the potassium. That is most important. Okay. Coming to the next. Which condition commonly causes high output heart failure? That is myocarditis, critical AS, severe anemia, or coarctation. Good number of people have answered and majority are right. It is severe anemia, which is a correct answer. Coming to the last question of the day. Which hormone directly causes vasoconstriction and stimulates the thirst? Insulin, calcitonin, glucagon, or angiotensin 2? Yeah, and almost all are right. 56 people have rightly said it is angiotensin 2. So before the result comes, this is the last poll question. How was the quiz? Very easy, medium, or hard? Your response will help us to make the quiz better and better every time. And every opinion counts. So please, those who have played, give your opinion. And it was said a medium quiz. 32, 9 easy, 7 very easy, and only 9 said hard. So it's a combination. So that means we can have this type of quiz. Thank you so much, and let's see the podium. Please don't leave it, because these winners will be given the prizes. The third winner, CM, please preserve this screenshot. The second, Shilpa, and the first is Sitara. If I'm not wrong, Sitara was also a winner back, and just to show all the 11 winners who will be getting the prizes, the first winner will get 3,000, the second 2,000, and next 9 winners will get 1,000 cash. For that, you are supposed to send the screenshot on aopgujarat@gmail.com or to my WhatsApp number 989863128 I'll request Nehal ma'am if you can just. Yeah. Is the screen still visible?
Yes.
Yes.
Okay. Can you see the winner names, ma'am? So overall 80 participants were there, sir, though the 60 were coming as a correct answers every time. And these are the top 11 winners. Sitara with 96% accuracy. See, if you see, she has given one wrong answer, but scored 31,954. And Shilpa, 100% correct answer. Congratulations to her. But because of the speed mismatch, she is second. Then CM, please send us your name, MJ, then Aditi Agarwal, then Dr. NK, then Dr. Eddie Bravo. Again, I think Eddie Bravo is persistently coming as a winners list.
Yeah.
Tulip, Mohammad, Hasina, Vikas Kateva, and Viktil Vikas Kateva are the winners, 11 ranks. So I'm just taking the screenshot of this. And thank you so much to one and all for playing.
Thank you so much, Prashant, for conducting the quiz so nicely. Every time you are the AI master, but still it requires a lot of things as we are learning the AI from him nowadays. So we know the prompt and everything also takes a time and the brain both. So thank you so much, Prashant, for doing this and connecting all of us to the academics through your quiz. Thank you so much. Thank you, Yogesh Sathe sir, once again for the wonderful heart failure presentation lecture. As as you see, everybody has attended it so nicely that the quiz questions were coming 100% right almost. So thank you so much, and thank you all the attendees. Without this program, without you all, the program is not a success. So thank you once again, all of you. Thank you, Lata. Every time she is taking a pain, coordinating everything, and being there in the session. Thank you so much. Thank you, Jhankhana madam, for encouraging us. Thank you, Zorvia, with your participation and the promotion to all the students for getting into the quiz. Thank you so much.
Good night.
Thank you. Thank you so much.
Good,
Thank you for giving me the
good night,
opportunity.
everyone.
Good night. Good night.
Good night. Let's meet
Night.
next
Night.
Thursday. Thank you.
Yes, yes.